Saeedi, a well-known respiratory consultant in Kuwait and the head of respiratory medicine unit in our hospital. Dr. Abdullah is a fellow of American board and Canadian board in internal medicine. He is also a fellow of American Academy in sleep medicine. Dr. Abdullah is ACCB regent to Kuwait. Our topic is challenging and it is related to IPF and how to connect the dots to reach the diagnosis and treatment. Dr. Abdullah.
Thank you, Adil. Today I'm going to talk about IPF. IPF is one of the well-known fatal diseases actually, with a life expectancy between 2 to 5 years. And it kills more than CA breast and CA colon combined, with no really a magic or a cure for this disease. Over the last 10 years, or actually less than 10 years, there was a huge shift in the line of the management of IPF. So I'm going to concentrate really about the few updates about this disease rather than the usual symptoms and diagnosis. The main management principles in managing patients with IPF is to prevent disease progression, prevent the exacerbation, improving exercise and quality of life, improve the symptoms, dyspnea and the cough, treating comorbidities, and improving overall survival. So in order really to prevent the progression of the disease, we need to know what are really the tools that we use to monitor this disease. The most important thing that to monitor is the forced vital capacity. The FVC is well correlated to overall mortality. Patients with these most if you look at the left, those with the more severe disease, FVC less than 50, they have the higher mortality. And on the right side, those with more than 10% drop in on their FVC annually, they are at higher risk of death. So this is an important tool to monitor every 3 months, supposed to be done for patients with IPF. The other objective measure that we use is the GAB score. GAB score is a multidimensional score that correlates gender and age and the physiology, forced vital capacity and DLCO, into a scoring system. So the total points from here is 8 points, and then they're graded into stage 1, 2, and 3. Those with stage 1, those are the mildest, and those with the stage 3, the severe. And as you see, as the disease progresses and the score high, the mortality is high. So these are the two main objective measures that should be used in a follow-up of patients with IPF. Now, one breakthrough actually in the field of IPF is the identification of genetics. Mucin P gene polymorphism was found to be very well correlated with severe disease, despite giving whatever medication that you are giving. So this is, it's been established. There are studies right now looked into this issue, what kind of modalities of treatments will be available for this disease. The treatment since 2011 changed in IPF from the publication of Panther study, which showed the failure of immunosuppressant and steroids. The concept of IPF was changed from anti-inflammatory to anti-fibrotics, because all the studies done previously for anti-inflammatory all failed. So the trials that came out with specifically for 2 drugs, mainly the birfenidone, which we have it here in Kuwait, and Esprit, and the nintedanib, which we have it also here in Kuwait as an OFEV. These are the 2 drugs available for IPF. Birfenidone, it inhibits TGF beta and TNF alpha effect. It has an anti-inflammatory and anti-fibrotic, and the more than 6 trials done on this medication all showed an improvement in lung function, forced vital capacity, on progression-free survival, and on 6-minute walk test. So this is one of the medications. At the same time, from Ascend trial, this is also on birfenidone. Those who worsened, so it's slowed down the progression of the drop of FVC and stabilized around 23% compared to 10% of the placebo. So this is one of the medications. The other medication, nintedanib, which is OFIV, it is an intracellular inhibitor of tyrosine kinase. There are Tomorrow trial and Impulses 1 and 2 trial mainly. These trials also showed the pooled analysis of Impulses 1 and 2, showed the improvement in lung function and the patient-reported outcomes, which is the St. George Respiratory Questionnaire, and the first exacerbation. So it helps in preventing exacerbation. The same thing story compared to aspirate, birfenidone. It's also improved lung function 30%, which is really only by numerical, by statistics, but really is it clinically relevant? It was not really clinically relevant. So simply saying that rather than improvement, was stabilizing the lung function. And the decline was also decreased with nintedanib. So this is a table just summarizing the effects of Ascend, and which is birfenidone and Impulses. You can see the primary outcomes in these trials was the drop in lung function, which both did well. And the other parameters showed improvement in 6-minute walk test and free survival, time to first exacerbation more with Impulses, and the overall mortality more with birfenidone. The Impulses 1 and 2 pooled data was not really, I know that's written here 30% risk reduction, but when we looked at the data, that was under question about the mortality effect. The main side effects for birfenidone, mainly they have a skin hypersensitivity. That's why when we are giving a patient birfenidone, we ask them to avoid exposure to sun or have a sunblock, beside the GI symptoms. Of the nintedanib, it's mainly a GI effect, side effects, but both are manageable and treatable. So, conclusion number one, to know that birfenidone and nintedanib are both efficacious in IPF, reducing annual decline in FVC. You cannot compare it head to head, okay, because there are different populations. Birfenidone reduces decline in 6-minute walk test, improves progression-free survival and overall survival, while nintedanib prolongs the time to first exacerbation. There was positive trends were seen in different patient-reported outcomes for both drugs. That's more of the respiratory questionnaires. And their side effects are manageable, and there is no evidence that N-acetylcysteine is effective in IPF. Now, this is an issue I'll come right now, because this issue will not really fade away, the issue of N-acetylcysteine in IPF patients. The first trial, Emphigenia, showed a positive. That was more than 10 years back. The follow-up of Panther trial, it was negative. So it's even among the people for the FDA, when they looked, there was a controversy among them. So what they did, with the recent, they found the mucin 5P, they looked into the genetics, this genetics abnormality, if it's really influenced the response of acetylcysteine in IPF patient. So the question of that study, of this study, is are a single polymorphism of the tolerant reactive protein TOLIP really is it linked to the efficacy of N-acetylcysteine in patient in Panther cohort? So it was post hoc analysis, and what they found, interestingly, that those patients with CC genotype of TOLIP, okay, they did bad. Those with TT genotype of TOLIP, they did well. So actually, a genetic basis will be the future for this. The conclusion here, as I said, N-acetylcysteine may be effective in patients with IPF if they have TT genotype of mucin 5B, of the TOLIP, okay? And those with the CC genotype, they do bad. So a stratified genetic prospective trial is really needed before giving any recommendation with giving an acetylcysteine in patients in IPF. So patients with IPF, the only available for them are birfenidone and nintedanib. The open questions always would be asked: when it should be started? Should those who have the pathology or the radiology showed a possible or definite or probable IPF pattern will be treated the same? When it should be stopped, and what about the other modalities? If we look at the Ascend trial and Impulses 1 and Impulses 2, there are different really in the patient population with regard their lung function. All of them, they improved, but there are different degrees. The natural history of the patients with IPF, 60-70%, they will progress. Okay, 30-40%, they may stabilize. Now, one can say, let's wait and see if they progress, then we start, rather than start early. This is a study, they looked into the value of forced vital capacity at 3 months. If they are stable at 3 months, is it enough for them to just withhold treatment, don't start it, or no? What they found that at forced vital capacity is good to monitor the patient, but you should not rely on starting or stopping treatment based on that only. It just gives you the hint that you need to go ahead, okay? Because 2/3 who've been stable at 3 months, they progressed over 1 year, okay? So it's not really an indicator that to stop it. Now, this is an important trial that gives us when to start. What they found from this study, on the left and on the right side there, those with moderate to severe disease, IPF, and the left side, those with mild disease. What they found that the patient with the milder disease, the more response they will get, rather than the severe disease. If you look at this is simply before birfenidone, this is after birfenidone, and the same thing. So, okay. So the less severe disease and moderate progression showed more consistent response to treatment. So when there are limited data, but this is one study, the overall risk relevant progression within 1 year is at least 50% they will progress, irrespective of disease severity and or they are an actively progressive disease, they will get further progression. Treating later, okay, it gives you they may respond, but you started really late, and there is no evidence when to stop at all. So IPF patient, once diagnosed, they should have the treatment offered, regardless of their stage, okay? So what about the definite, probable, and possible? The green is the impulses. That's where they used nintedanib. If you look, whether they have surgical lung biopsy or pathology panel, the panel, possible UIP pattern patients, the majority of them actually, and the nintedanib were possible, not definite UIP pattern. They've been recruited, and despite that, there was a benefit of giving this treatment. So that started a different pathway from IPF patient, because almost any disease, interstitial lung disease, they end up with fibrosis if left alone, okay? Now, those diseases who are progressive in nature, they may get the benefit. I mean, we will have the answer once this trial completed. This is an ongoing trial right now in 19 centers in Germany. It's called RELIEF. They are looking for the value of birfenidone and non-IPF patient and other modalities rather than IPF, other diseases rather than IPF patient. And they're aiming around 550 patients. They have recruited already around 370 patients right now. And we are, it's a 48 weeks. And
5 minutes.
5 minutes.
4 minutes?
5.
زيد واحدة.
5.
طيب. Okay. So this is the inclusion criteria, so we'll wait for that. Another modality important for treatment is pulmonary rehab, which is unfortunately we don't have it here in Kuwait. It improves the 6-minute walk test and also improve the psychological score. Even patients with pulmonary hypertension, they're getting the improvement. So generally pulmonary rehabilitation is indicated in all patients with IPF. They can have various comorbidities. The most important one I'm going to talk about is reflux disease. The previous trials, they looked into is reflux disease can make IPF worse or no? We don't know. Is the treatment of GERD will improve their outcome? So this is a trial looked into the value of the patients who've been giving BBI or H2 blockers for patients with IPF. What they found that it slows down the decline in forced vital capacity. So let's connect the dots. Prevent disease progression, birfenidone, nintedanib, and enrollment in clinical trials. That's the rule right now. Improving exercise, tolerance, and quality of life, birfenidone, pulmonary rehab, and nintedanib. Improving symptoms, oxygen, PPI for the cough, if they have reflux, and thalidomide. There is a small trial looked into the thalidomide value in patients with intractable cough from IPF. Treating comorbidities, GERD, if they have BBI and H2 blockers, and pulmonary hypertension. Preventing exacerbation, well proven with OFF only, nintedanib, and improving survival with birfenidone and nintedanib, and lung transplant. So this is the general principle, mild to moderate. All of them, they need to be assessed up front to lung transplant. Any IPF patient, if they are indicated or not. Severe disease patient, usually they are not really well responders to the antifibrotics. So pulmonary rehab indicated and follow up every 3 months. The latest guidelines from IPF, not anymore recommended, the anticoagulation, imatinib, the steroids, immunosuppressant, and the pulmonary hypertension treatment, abrisentan. Negative recommendation or the conditional for Viagra and other pulmonary hypertension. Positive only for OFF and Esprit. This is the last slide. Okay, this is just to show it for the people who are interested in this, which patient should be assessed for lung transplant, or who is actually the candidate for the lung transplant. And thank you.
We invite the speakers to the panel for discussion.
This question for Dr. Abdullah. Since there is now, the future, as you mentioned, regarding the pharmacogenetics, is available for around 100 kind of drugs. Do you recommend, that for any patient now to start look ahead for that testing to decide what kind of drugs you want to start with the patient?
The genetics, what they found here is for specifically, they looked into one aspect, one drug, which is N-acetylcysteine, okay? That's the genotype based right now for the N-acetylcysteine. We don't know, really. There are over 12 trials right now. They are looking into genetics, other genetic processes, but the only available treatment right now for the IPF are birfenidone and nintedanib. They need to go ahead for lung transplant, initially assessed, but for genetic, I think that would be the future, not really for only IPF, almost any disease.
Thank you.
Thank you very much, Dr. Bilqis and Dr. Abdullah, for these nice updates. I just have a question for Dr. Bilqis. You have said that, among the fractures, the compression fracture for vertebra is more looked after. But in common practice, we see a lot of hip fractures, which are more commoner. So I don't think the screening, as you said, we should also concentrate on the hip fracture. What is your comment on this?
Screening is recommended in terms of vertebral fractures, compression fractures of the vertebra with loss of height.
if you have a loss of height of 4 centimeters historic or 2 centimeters new, they should get an X-ray in order to see the compression fracture. There is no guidelines, there is no recommendation to do a hip X-ray as such, but anybody with a risk of hip fracture or has had a history of hip fracture should be treated as osteoporosis. I mean, it makes him or her osteoporotic if they had a hip fracture or a vertebral compression fracture or a low trauma fracture. So they should be treated even if they are in the osteopenic range.
For Dr. Bilqis, excuse me, as regarding vitamin supplement in geriatric population, what about vitamin K2 in supplementation of geriatric as prevent or treat osteoporosis and prevent atherosclerosis?
There are no recommendations about vitamin K2 as such. The only vitamin that is recommended routinely is the vitamin D. Multivitamins by itself are also not routinely recommended unless you have deficiencies of those. Calcium and vitamin D are the only supplements that are routinely recommended. K2, and it's not even recommended to check any levels that I have come across.
Any more questions?
Thank you for Dr. Abdullah Saeedi and Dr. Bilqis, the chairpersons, Dr. Muhsin, Dr. Rada, Dr. Adil. Now is the praying and coffee break for 20 minutes, please.